Dr. Desmond White, gastroenterologist. When do we call anesthetist for endoscopy? Well, there are a few scenarios. If a procedure is fast and simple and the patient is an easy patient, I do not call the anesthetist. I just give my own sedation. I use midazolam to put them to sleep, fentanyl or petadine to reduce the pain, and propofol to help them sleep. Most of the time, patients do well in all these things. So for gastroscope, colonoscopy, for a normal person, I just do it myself. The nurses help me give the sedation. The nurses help me monitor the patient. Nowadays, we monitor the patient very seriously. We will put them on the ECG list, give them oxygen, intravenous oxygen, check the pulse for the oxygen level in the blood, and check the blood pressure and pulse, etc. during the procedure. However, when the patient is too young that we think they are difficult to sedate, like those are below 14, 15 years old, also they're very elderly that we think they may be very sensitive to sedation. Say if you have an 80-plus-year-old man, sometimes a little bit of sedation may tip them into deep sleep and then it may not be so good. We need to wake them up. So in too young and too old, I use anesthetists. In patients that have medical issues like they have lung problem, heart problem, that I think the margin of error is very small, I call anesthetist as well. And certain procedure like endoscopic mucosal dissection and a difficult polypectomy, or in procedure called endoscopic retrograde cholangiography ERCP, we use anesthetic as well because for those ERCP, for example, the margin of error is very little. We want to put the cannula into the opening of the bowel duct. The moment the patient moves a little bit, we may just miss it. So we want patient to be completely motionless. And also ERCP can sometimes it can be as fast as 15 minutes job. It can be as long as 1 hour. So any long procedure is probably safer to get anesthetists involved to sedate the patient and monitor the patient, so me as an endoscopist can focus on the procedure. So to sum up, in a very difficult, complex procedure like ERCP or endoscopic mucosal resection, we call anesthetists. In patients that are too young or too old, we call anesthetists. In patients that have chronic illnesses that we think they may a little bit of sedation may tip them over to be in a decompensated state, we call an anesthetist. I do not call the anesthetist all the time. I give it myself. So the question is, why don't I call the anesthetist all the time? Well, there's several reasons for that. Number one reason is that when I call the extra doctor to come in, we run a private practice and there will be extra cost to the patient or to whoever to pay the bill for the patient. I think if we need it, we spend it, but if we don't need that, then we don't have to spend the money. Number two is that if a short procedure, it's probably much easier to do it myself, to wait for another guy to come in or lady to come in and then do the anesthetist. But if the patient needs anesthetist, the anesthesia, I will not stinge on them. I will convince the patient to pay a little bit more to another doctor come to make the whole procedure more comfortable. To sum up, certain patients, certain procedure require anesthetists, but you probably don't need an anesthetist for all the endoscopic procedure. Dr. Desmond White.